Good afternoon, my name is Robin Danek, and this afternoon I'll be talking to you about my study which examines the effect of cognitive behavioral therapy on medically assisted treatment. First, a little bit of background though. The U.S. is in the midst of an opioid epidemic. Since 2000 there's been a substantial increase in opioid use disorder. In fact, from 2013 and 2014 there was a 9% increase in prescription drug-related deaths and a 26% increase in heroin-related deaths. Rural areas have been particularly hard hit by this, particularly because there is a lack of access to drug treatment centers and drug treatment in general. One effective way of addressing this problem is through medically assisted treatment, which consists of two components: medications and counseling. Medications can include methadone, buprenorphine, or naltrexone. For this particular study, I will be concentrating on buprenorphine because it is a medication that can be distributed on an outpatient basis by primary care physicians, which is an attractive alternative for rural areas where you don't have ready access to a methadone clinic or any sort of drug treatment program. And while there are specific guidelines about medications and how that is to be administered, there are no specific guidelines about the type of counseling administered during MAT. Cognitive behavioral therapy, which I'll refer to as CBT in this presentation, is effective in treating a variety of substance abuse disorders, including alcohol abuse and cocaine abuse. Patients undergoing CBT have been found to be drug-free for longer periods of time. In a recent 2009 meta-analysis of examining 53 randomized controlled trials, McGill and Ray found that overall CBT produced statistically significant treatment effects regardless of the substance being abused. And while there's been quite a few studies looking at the combination of cognitive behavioral therapy and a variety of different substance abuse, there's been very few looking at the combination of cognitive behavioral therapy and buprenorphine on opioid use disorder. In fact, I only found 3 different studies that address this particular area. And those studies are listed up here, and they are Moore, Fineline, and Lang's studies. Each study found that there was no significant difference between groups receiving cognitive behavioral therapy and other types of therapy when used in combination with buprenorphine. However, these studies were seriously flawed. In some, the cognitive behavioral therapy was optional, and another, there were no proper control groups, and in another, the actual time that treatment was administered was for less than 3 months. For my proposed study, my first aim is written up here. I would like to, the first aim is to examine the effect of cognitive behavioral therapy has on the completion of a MAT program. So my hypothesis is that patients living in a rural area undergoing cognitive behavioral therapy from a trained behavioral health specialist are more likely to complete a MAT program. There will be 3 cohorts. One will receive cognitive behavioral therapy from a behavioral health specialist. Another one will receive usual counseling, so no specified type of counseling from an untrained primary care physician. And then a third will receive counseling from a primary care physician who has training in addiction medicine. This is in order to control for possible physician training effects. So we can parse out whether cognitive behavioral therapy is effective depending on who is actually delivering it, or if it's the cognitive behavioral therapy itself. The outcomes for this particular aim will be the completion of a MAT program and relapse. The measures will be a clean urine test, readmission to a hospital or drug treatment program due to a drug-related illness, and the number of appointments attended, both primary care physician appointments and then for the treatment group also for behavioral health specialist appointments. My second aim will be to determine the effectiveness of cognitive behavioral therapy on health outcomes enrolled in a MAT program. So patients receiving cognitive behavioral therapy from a trained counselor will be more likely to be drug-free at 6, 12, and 18 months. That's my hypothesis. My outcome will look at the absence from opioids, employment, legal status, so whether or not they've been arrested or not, drug use behaviors, and satisfaction with therapy. These will be measured through urine tests, self-reported drug use behaviors, and satisfaction with therapy. So this study is a departure from previous studies. First of all, we're looking at a rural population. In the 3 previous studies I referred to, Moore, Phelan, and Ling, they were all centered on an academic center or an urban area. This is focusing on a rural population, which again, as I said earlier, there's a high need because there are few treatment options. I'm also controlling for the effects of physician training, which has not been controlled for in previous studies. And the intervention will be 6 months long. So we'll measure at the end of 6 months, 12 months, and 18 months. The impact, this study has the potential to influence how treatment is delivered. If we are found, if it is found that cognitive behavioral therapy is impactful on treatment outcomes, this can affect how we allocate resources as well. And this is particularly important in rural areas. Here are my references.